Welcome. This is the New England Journal of Medicine. I'm Dr. Lisa Johnson. This week, October 3rd, 2024, we talk about lenacapavir for HIV prevention in cisgender women, tirzepatide for treatment of obstructive sleep apnea, lymphadenectomy for muscle-invasive bladder cancer, secondary T-cell lymphoma after CAR T-cell therapy, and immunity and early colorectal carcinogenesis, a review article on prolonged grief disorder, a clinical problem solving on avoiding rash decisions, and perspectives on healthcare reform and the 2024 U.S. elections, on financial toxicity for patients from the use of AI, on the Supreme Court's shadowy treatment of public health, and on caring for our communities. Twice yearly lenacapavir or daily FTAF for HIV prevention in cisgender women. By Linda Gale Becker from the Desmond Tutu HIV Center, Cape Town, South Africa, and co-authors. There are gaps in uptake of, adherence to, and persistence in the use of pre-exposure prophylaxis for HIV prevention among cisgender women. In this trial, adolescent girls and young women in South Africa and Uganda were assigned in a 2:2:1 ratio to receive subcutaneous lenacapavir every 26 weeks, daily oral emtricitabine tenofovir alafenamide FTAF, or daily oral emtricitabine tenofovir disoproxil fumarate FTDF, the active control. Among 5,338 participants who were initially HIV negative, 55 incident HIV infections were observed. 0 infections among 2,134 participants in the lenacapavir group, 39 infections among 2,136 participants in the FTAF group, and 16 infections among 1,068 participants in the FTDF group. Background HIV incidence in the screened population of 8,094 participants was 2.41 per 100 person years. HIV incidence with lenacapavir was significantly lower than background HIV incidence, rate ratio 0.00, and than HIV incidence with FTDF, incidence rate ratio 0.00. HIV incidence with FTAF did not differ significantly from background HIV incidence, and no evidence of a meaningful difference in HIV incidence was observed between FTAF and FTDF. Adherence to FTAF and FTDF was low. No safety concerns were found. Injection site reactions were more common in the lenacapavir group. 4 participants in the lenacapavir group discontinued the trial regimen owing to injection site reactions. No participants receiving twice yearly lenacapavir acquired HIV infection. HIV incidence with lenacapavir was significantly lower than background HIV incidence and HIV incidence with FTDF. Rochelle Walensky from the Harvard Kennedy School of Government, Cambridge, Massachusetts, and Lindsay Baden, deputy editor for the journal, write in an editorial that in the trial by Becker and co-authors, of the 55 incident infections among participants in the 3 intervention groups, there were none in the lenacapavir group. This efficacy exceeded the predefined stopping criteria, and the trial was stopped early. With approximately 92% attendance for the twice-yearly lenacapavir injections, the trial by Becker and co-authors exemplifies not only that women can dependably adhere to this administration schedule, but also that levels of an HIV-1 capsid inhibitor can remain high enough over a period of 6 months to reliably prevent infection. A key challenge to decreasing the incidence of HIV infection is identifying high-risk populations, especially women, engaging them, and providing them easy, low-barrier, and low-cost access to a PrEP regimen that works and to which they can adhere. The results of this trial have now created a moral imperative to make lenacapavir broadly accessible and affordable as PrEP to persons who were enrolled, as well as all those who are similarly eligible and could benefit. We now have a PrEP product with high efficacy. That is great news for science, but not yet great for women. The imperative now is to spend time, resources, and political will on access, implementation, and delivery. That plan must include a mechanism to finance these drugs so that the women who have borne an unacceptably high HIV infection burden and who have volunteered for decades in studies of HIV prevention can reap the PrEP benefits and remain HIV-free. Tirzepatide for the treatment of obstructive sleep apnea and obesity by Atul Malhotra from the University of California, San Diego, La Jolla, and co-authors. Obstructive sleep apnea is characterized by disordered breathing during sleep and is associated with major cardiovascular complications. Excess adiposity is an etiologic risk factor. Tirzepatide is a long-acting, glucose-dependent, insulinotropic polypeptide (GIP) receptor and glucagon-like peptide-1 GLP-1 receptor agonist that selectively binds to and activates both the GIP and GLP-1 receptors. In 2 phase 3 trials, participants were randomly assigned to receive either the maximum tolerated dose of tirzepatide or placebo for 52 weeks. Participants who were not receiving treatment with positive airway pressure, PAP, at baseline were enrolled in Trial 1. In Trial 1, the mean apnea-hypopnea index, AHI, the number of apneas and hypopneas during an hour of sleep, was 51.5 events per hour, and the mean BMI was 39.1 at baseline. The mean change in AHI at week 52 was minus 25.3 events per hour with tirzepatide and minus 5.3 events per hour with placebo. Participants who were receiving PAP therapy at baseline were enrolled in Trial 2. In Trial 2, at baseline, the mean AHI was 49.5 events per hour, and the mean BMI was 38.7. The mean change in AHI at week 52 was minus 29.3 events per hour with tirzepatide and minus 5.5 events per hour with placebo. Significant improvements in the measurements for all pre-specified key secondary endpoints were observed with tirzepatide as compared with placebo. The most frequently reported adverse events with tirzepatide were gastrointestinal in nature and mostly mild to moderate in severity. Among persons with moderate to severe obstructive sleep apnea and obesity, tirzepatide reduced the AHI, body weight, hypoxic burden, high sensitivity C-reactive protein concentration, and systolic blood pressure, and improved sleep-related patient-reported outcomes. In an editorial, Sanjay Patel from the University of Pittsburgh writes that the weight loss was accompanied by a reduction in the apnea-hypopnea index as compared with placebo, the primary endpoint, of 20 to 24 events per hour, a relative reduction in events of 48 to 56%. However, whether tirzepatide improves patient-centered outcomes in obstructive sleep apnea remains unclear because a change in the AHI has not been validated as a surrogate marker of clinically relevant endpoints. The initial results from the trial by Malhotra and co-authors show the usefulness of tirzepatide as an adjunctive treatment to address coexisting obesity in patients with obstructive sleep apnea. Weight loss resulting from tirzepatide treatment may be leveraged to expand the populations that may benefit from second-line treatments for obstructive sleep apnea, such as mandibular advancement devices or hypoglossal nerve stimulation. Additional analyses of the effects of tirzepatide on a broader range of patient-reported outcome measures by Malhotra and co-authors will be eagerly awaited to evaluate the potential utility of tirzepatide as a sole treatment for obstructive sleep apnea. If the results of those analyses are promising, the news of an addition of a pharmacologic option to the clinical armamentarium for obstructive sleep apnea will be welcomed by many patients and clinicians alike. Standard or extended lymphadenectomy for muscle-invasive bladder cancer. By Seth Lerner from Baylor College of Medicine, Houston, Texas, and co-authors. This study evaluated whether extended lymphadenectomy is associated with improved disease-free and overall survival, as compared with standard lymphadenectomy among patients with localized muscle-invasive bladder cancer undergoing radical cystectomy. 658 patients with localized muscle-invasive bladder cancer of clinical stage T2 confined to muscle to T4A invading adjacent organs with 2 or fewer positive nodes were randomly assigned to undergo bilateral standard lymphadenectomy, dissection of lymph nodes on both sides of the pelvis, or extended lymphadenectomy, involving removal of common iliac, pre-sciatic, and presacral nodes. At a median follow-up of 6.1 years, recurrence or death had occurred in 45% of patients in the extended lymphadenectomy group and in 42% of those in the standard lymphadenectomy group. And the estimated 5-year disease-free survival was 56% and 60% respectively. Overall survival at 5 years was 59% in the extended lymphadenectomy group and 63% in the standard lymphadenectomy group. Adverse events of grade 3 to 5 occurred in 54% of patients in the extended lymphadenectomy group and in 44% of those in the standard lymphadenectomy group. Death within 90 days after surgery occurred in 19 patients, 7%, and 7 patients, 2%, respectively. As compared with standard lymphadenectomy, extended lymphadenectomy did not result in improved disease-free or overall survival among patients with muscle-invasive bladder cancer undergoing radical cystectomy, and was associated with higher perioperative morbidity and mortality. Aggressive lymphoma after CD19 CAR T-cell therapy by Guido Kobe from the University Hospital Düsseldorf, Germany, and co-authors. These authors describe a case of aggressive CAR T-cell lymphoma and investigate its lymphomagenesis. A 60-year-old man with primary central nervous system lymphoma received treatment with tisagenlecleucel for relapsed primary central nervous system lymphoma. 1 month after the patient received the treatment, the development of a fatal clonal, autonomously proliferating CD4-CD8 CAR peripheral T-cell lymphoma occurred. The peripheral T-cell lymphoma had a clonal T-cell receptor rearrangement, which was already detectable in the apheresis product for CAR T-cell manufacturing and 7 months earlier for autologous transplantation. Somatic DNMT3A and TET2 mutations in CD34 stem cells and their progeny were detected in the peripheral T-cell lymphoma, in the apheresis specimen that was obtained for CAR T-cell production, and in the auto transplant. The peripheral T-cell lymphoma harbored an additional somatic TET2 mutation, which was already detectable in the CAR T-cell apheresis product and the final CAR T-cell product at very low frequencies, providing evidence that clonal hematopoiesis had contributed to lymphomagenesis. The patient died from hemorrhagic shock approximately 2 months after CAR T-cell therapy. Prolonged grief disorder, a clinical practice review by Naomi Simon from New York University Grossman School of Medicine and M. Catherine Shear from Columbia School of Social Work, New York. Prolonged grief disorder is a post-loss stress syndrome in which grief after a death remains intense and preoccupying longer than is expected according to social, cultural, or religious norms, a minimum of 6 months according to the International Classification of Diseases and Related Health Problems 11th revision, or 12 months according to the Diagnostic and Statistical Manual of Mental Disorders 5th edition. Persistent, intense yearning, longing, or preoccupation with the deceased person and other grief-related symptoms cause clinically significant distress and impairment. An estimated 3 to 10% of persons who are bereaved owing to a death by natural causes have prolonged grief disorder, with substantially higher percentages among persons whose bereavement is caused by death of a child or partner, or is the result of a sudden unexpected death, such as violence or suicide. A simple patient-reported rating scale can be used to screen and monitor persons with prolonged grief disorder. Clinical evaluation of possible prolonged grief disorder should also assess other mental health conditions, including depression, anxiety, post-traumatic stress disorder, alcohol and substance use, suicide risk, and effects of symptoms on social and occupational functioning. The fundamental goals of treatment are to help the person learn to accept the permanence of the loss and to restore the capacity to have a meaningful, satisfying life without the deceased person, so that yearning and preoccupation with the deceased person subside. Evidence-based, grief-focused psychotherapies constitute first-line treatment. Avoiding Rash Decisions, a clinical problem-solving by Dylan Iger and co-authors from Brigham and Women's Hospital, Boston. A 40-year-old man presented to the emergency department with a 5-day history of fevers, sore throat, fatigue, subjective weakness, and muscle and joint pains. 1 day earlier, he had presented with similar symptoms. Testing for SARS-CoV-2, influenza, RSV, and streptococcus was negative. He was initially discharged with instructions to take acetaminophen and ibuprofen, but the odynophagia and myalgias progressively worsened. On current examination, pharyngeal erythema and swelling of both tonsils without exudate were observed. Range of motion of the jaw was limited by pain. Swelling was seen in both wrists. Pain limited the active range of motion in both wrists, hips, and shoulders, with the right shoulder being the most limited. Laboratory results showed leukocytosis and neutrophilic predominance and elevated levels of inflammatory markers, as well as an elevated erythrocyte sedimentation rate and C-reactive protein level. The patient was admitted to the hospital and treated with intravenous ampicillin sulbactam to cover common causes of bacterial tonsillopharyngitis. Adult-onset Still's disease was considered, given the patient's fever, pharyngitis, and arthritis. However, this condition is rare, and diagnosis requires that alternative diagnoses be ruled out first. 2 days after presentation, fevers developed, and the patient had worsening odynophagia that led to the use of intravenous fluids and opioids. An evanescent salmon-colored rash developed. Laboratory results showed elevated ferritin and aminotransferase levels. The patient received a diagnosis of adult-onset Still's disease and was treated with subcutaneous anakinra, an interleukin-1 receptor antagonist. Reactivation of SOX17 program as immune evasion mechanism in early colorectal cancer development. Clinical implications of basic research by Aysel Ahadova and Matthias Kloa from the Centers for Disease Control and Prevention, Fort Collins, Colorado. Goto and co-investigators recently described a novel mechanism of immune evasion during the initial steps in the development of colorectal cancer, in which nascent cancer cells reactivate a fetal program that is usually switched off in adults. Specifically, they implicate the re-expression of a protein called SRY box transcription factor 17, SOX17, in mediating immune evasion during the formation of colorectal cancers. SOX17 plays a crucial role in fetal development, including the formation of the gut endoderm and the vascular system, but also endometrial embryo receptivity, acting mainly by ensuring an immune-tolerant environment. In adults, SOX17 is usually epigenetically silenced, which enables immune surveillance through upregulation of major histocompatibility complex MHC class I expression and the interferon gamma receptor. During the initial phases of colorectal cancer development, LGR5 negative epithelial cells can reactivate the fetal SOX17 program and thus reduce the susceptibility of tumor cells to interferon gamma, down-regulate MHC class I expression, and suppress T-cell infiltration. Thus, an immune-suppressive environment is established, enabling tumor outgrowth. Goto et al. Describe a fascinating mechanism of early cancer immune evasion that will require confirmation. Healthcare reform and the 2024 U.S. elections. Low visibility, high stakes. A perspective by Jonathan Oberlander from the University of North Carolina, Chapel Hill. Abortion and reproductive health have emerged as a major focus in the 2024 U.S. presidential campaign. The 2022 Supreme Court decision overturning Roe v. Wade and the ensuing spread of abortion bans and restrictions in many states has propelled the issue to the forefront of American politics. While reproductive health has drawn the spotlight, less attention has been focused on other health policy issues, such as the uninsured and underinsured populations, healthcare costs, and Medicare. Medicaid, too, has drawn scant notice, despite seeing disenrollment of more than 25 million people since 2023, owing to the expiration of the continuous coverage provision of the Families First Coronavirus Response Act of 2020. Issues such as the economy and immigration are predominant, reducing the visibility of healthcare, apart from abortion. But there is another explanation for why neither Democrats nor Republicans have offered sweeping reform plans: the success of the Affordable Care Act, which was strengthened by policies adopted during the Biden administration. In the ACA's shadow, both parties lack a clear plan for future healthcare reform. U.S. health politics has, for now, returned to incrementalism, with proposals that promise small changes rather than transformation. And if the election produces divided party control of the White House and Congress, the prospects for transformative change will be further constrained. Though healthcare reform has garnered only limited visibility in this campaign, the stakes of the 2024 elections for its future are high. Avoiding financial toxicity for patients from clinicians' use of AI. A perspective by Sneha Jain from Stanford University, California, and co-authors. As artificial intelligence (AI) tools in healthcare mature, healthcare organizations are beginning to focus on the financial implications of AI adoption. Although some stakeholders have considered how healthcare systems should be paid for appropriate AI use, they have largely overlooked the risk of financially burdening patients when clinicians make care decisions guided by AI. When validated AI tools recommend confirmatory diagnostic testing, patients may face new financial burdens if these recommendations are followed by their clinicians, but are not yet reflected in insurance policies. Only 37% of adults in the United States can pay an unexpected expense of $400 without borrowing money or selling an asset. This vulnerability makes it critical for healthcare systems deploying AI tools to understand and plan for financial risks to patients in the near term, and for insurers to change the way they make coverage decisions in the longer term. Gaps between what validated AI tools recommend and what insurance covers may exacerbate healthcare disparities between high-income and low-income patients. The potential benefits of AI use in healthcare are thus inequitably distributed. Clinicians and healthcare organizations should be aware of the potential financial implications to patients from following AI tools' recommendations, and the likelihood that real-world benefits of AI will be inequitably distributed if this problem is not addressed. It is critical to assess and mitigate these potential effects before deploying an AI tool and to advocate for changes in insurance coverage. The Supreme Court's shadowy treatment of public health. A perspective by Summer Engels from Harvard Law School, Cambridge, and co-authors. In late June, the U.S. Supreme Court issued an order halting implementation of the Good Neighbor Plan, a Clean Air Act regulation created by the Environmental Protection Agency with the goal of limiting the interstate spread of ozone-forming emissions. With this order in place, ozone pollution will continue to spread until the lower court involved in the case, and potentially the Supreme Court, decide whether the regulation should stand. Even if the Good Neighbor Plan is eventually upheld and takes effect, its implementation could be years behind schedule. The court's decision in the case Ohio versus EPA could endanger human health. Ground-level ozone has both short and long-term health effects. Exposure to ozone triggers local and systemic effects involving multiple organ systems, including the respiratory and cardiovascular systems. It is associated with the development and exacerbation of asthma and COPD, more frequent respiratory infections, and increased mortality. Several trends reflected in the order could also have troubling implications for public health and the administration of the Clean Air Act and similar regulatory statutes. The first issue relates to the Supreme Court's procedures. Because the petitioners in this case, a coalition of states and industry groups, sought a pause or stay of implementation of the Good Neighbor Plan while proceedings in the lower court play out, the case landed on the court's emergency docket. Disputes on the emergency docket are not subject to the procedures that govern the resolution of cases on the court's usual merits docket. The opinion in this case also reflects diminished regard for the importance of public health. Caring for our communities. A Perspective by Sujatha Sankaran from the University of California, San Francisco. Dr. Sankaran has recently taken on a role as the chief medical officer of a very small hospital affiliated with her academic health system. Although it's only an hour's drive away from a large metropolitan area with a glut of specialists, she has unwittingly ventured into a dead zone for subspecialty care and finds herself in a situation that a substantial percentage of physicians in rural communities face every day. Community hospitals are critical to rural and semi-rural regions, and people at this small community hospital have an intimate knowledge of the needs of the people they serve. The community, in turn, has a deep and abiding trust in the local hospital. But this small hospital also faces all the predictable pressures and tensions of a capitalistic health system model in an era of increasingly super-specialized care. Dr. Sankaran's hospital has all the right components: goodwill from the community, a deep bench of donors, affiliation with a larger and bigger name health system. But there is a shortage of subspecialty physicians in this small community. There aren't enough beds at close hospitals to accommodate the need. There simply isn't any incentive for the other hospitals to take their patients who are already sick and likely to get sicker when they are already overloaded with their own patients. Still, they create pathways for easing transfers. They hold meetings. The problem persists. A patient with a GI bleed who was previously transferred shows up again. He chooses the same ED, despite the hospital's inability to help him the last time. Because it's closer, because it's there, because he trusts this hospital. Dr. Sankaran hears the desperation in the ED doctor's voice. The patient is bleeding. He needs care that they can't give him at this hospital. Dr. Sankaran pauses, takes a deep breath, and enters the room for another round. In our images in clinical medicine, a 26-year-old man presented with a 1-week history of fevers and bloody stools. He had had condomless receptive anal intercourse with a new male partner 3 weeks earlier. A CT scan of the pelvis showed rectal thickening, and a flexible sigmoidoscopy showed nodular ulcerated mucosa. A nucleic acid amplification test for chlamydia trachomatis that was performed on a rectal swab was positive, with negative testing for L. serovars. A diagnosis of chlamydial proctitis was made. In another image, a 70-year-old woman was transferred to a specialty hospital for endovascular treatment of a ruptured intracranial aneurysm that led to a subarachnoid hemorrhage. During intraoperative angiography, the aneurysm re-ruptured approximately 10 hours after the initial rupture, shown in a video at NEJM.org. In the first 24 hours after an aneurysmal subarachnoid hemorrhage, there is a risk of aneurysm re-rupture, which is associated with higher mortality than a single rupture event. Despite immediate placement of an external ventricular drain and coil embolization of the aneurysm, the patient's postoperative neurologic status was poor. She was transitioned to comfort care. This concludes our summary. Let us know what you think about our podcast. Any comments or suggestions may be sent to audio@nejm.org. Thank you for listening.